Good morning, everybody. Nice to see so many of you here again today. This session, I think, really is a crystallization of everything we've been talking about and are here to talk about for 3 days. We know that there is a growing number of healthcare practitioners who are trained in countries that they don't live in. And increasingly, they're migrating in a global market for health and for health talent. But there isn't a consistent standard in how they're trained. So in this session, we're going to explore how training programs can be designed to attract a global workforce while also ensuring their skills are recognized and rewarded globally. Let me invite my 3 panelists up to the stage, and I'll tell you a little bit about them as they're coming up to join us. Please give them a round of applause. Crystal Lander is Associate Vice President of Global Advocacy at CARE. There, she leads global policy work and also financing for women's and girls' equality, health access, food and nutrition, and some financial inclusion programs. Guillaume Dedet is a senior economist in the health division at the OECD. He's also a public health physician. And at the OECD, he's primarily responsible for the comparative analysis of health system performance across OECD countries. And Stefan Wiesbauer is the co-chief executive officer of Lectorio, a company which provides an all-in-one digital platform for health education. Panelists, it's great to see you here this morning. Thank you so much for joining us. I'm going to throw out a question to all and any of you, and you each have a microphone on your chairs as well. And so please jump in, whoever wants to take it up. And the question is simply this. We have advocates, economists, edtech entrepreneurs, and technologists on this panel with us today. There's a lot of accolades you guys have. So with the perspectives that you each bring, what do you see as the biggest opportunity or challenge of doing what we're talking about doing here, creating and expanding international training programs for healthcare workers? Who wants to dive right in? Crystal.
Ladies first.
They're all looking at you.
So first, welcome, and thank you for allowing me to join you for this really important conversation. When it really comes down to it, we know how to do this. We have all of the ingredients. We know that good training, good health workforce needs support. They need to be supported. They need to be paid. They need all these things. They need opportunities. So I think what makes me excited is the fact that we do have this diversity in the room. There were plenty of times where we did not have the different actors and players in the space together to talk about how do we do it. And I think people are all looking for, everyone wants a strong health workforce in the countries they live in, and in low and middle income countries, the same. So now it's about how do we take those talents? How do we leverage the private sector? How do we leverage training units? How do NGOs, local civil society groups together to do this with the governments? And I think that makes me excited. I think the opportunity there is to get it right. How do we do this so it is fit for purpose, it's for the future, it incorporates not only what we need now, but we need for the next 40 years.
So that's the opportunity.
That's the opportunity.
Guillaume, Stefan, any ideas about challenges or other opportunities that you see?
Thank you, Stefan. Thank you, and good morning, everybody. I would say, from an economist perspective, what we are trying to always tackle is what we call market, inefficiencies or market failures. And I think in the context of the global health workforce, there are huge, inefficiencies that we see because today, if I bring just basic numbers, but today we have roughly in OECD countries 10%, 11% actually to be precise, of all manpower that works in health. Okay, so that's massive, and this has increased substantially in recent years. But despite this, we have still many challenges because the demand is much higher compared to the available number of people and staff that we have. So we see in the context of international migration and movements of the health workforce, major market failures. Why? Because we see today 2 problems, big challenges, and the good thing is that we know them, so if we know them, we're able to address them. The first one is brain drain. The fact that today we have 90,000 doctors working in OECD countries that come from countries that are on the safeguard list of WHO, meaning countries from where they should not be hired. And the other thing is the brain waste, because we also have doctors. I mean, people train as doctors that cannot work in OECD countries because of their situation, their recognition of their competencies and degrees. Today, 60%, for instance, in Canada, of the foreign-trained and foreign-born doctors and nurses actually don't work in the health field. So this brain waste is another major market failure. So we know the problem. So that's the good news. For the rest, we'll move it on.
Okay, so we have one opportunity, which is the diversity of actors at the table. We have a dual set of challenges, brain drain and brain waste. Stefan, what's your perspective on this?
Yes, first let me start by saying thank you to the hosts and organizers here. My first trip to Saudi Arabia was over 20 years ago when I was a McKinsey advisor for Saudi Aramco, and they're good memories, and a lot has changed since. My wife has been there recently. She works in the arts, and she was very pleased and really enjoyed her trip there. Aside from the Saudi coffee, she was very impressed by how things have evolved there. So thank you so much for having me. It's an honor to be here. In terms of the question, I think there's interesting challenges there. If we look at it as a stock and flow problem, maybe also like a little economist perspective, from the stock side of things, so we have this health workforce, but it's kind of draining because the job conditions are pretty tough, right? So nurses these days, are often wondering, like, is this sustainable for me? Is this the job that I want, right? So in terms of working hours, in terms of regulations, in terms of pressures, everything else, it's not easy, right? And so that creates a fundamental problem, of course, because then we don't know if the people that we have are even going to stay in the profession, and then we have to counter that outflow, if you like, with the inflow. When we talk about the inflow, then we have to recognize, I think, that the education methods are still very dated. The way we do this in Germany or many other countries. Digitization hasn't really entered it fully. The regulators keep things from advancing and being deployed that are readily available to make this more affordable, to make this more scalable, while keeping it quality or while even improving the quality, right? Then you have the underlying complexity around the international aspects, right? And those are complex, right? So you have countries that are on the blacklist of WHO in Africa where nurses are unemployed, right? So it's, and there's a fundamental challenge there, as I see it, in terms of making the case for the value of health in the wider economy. So it's often looked at as like, okay, of course we all want to be healthy, but if you do the mathematics on the value of good health to the economy, in terms of productivity, days of absence, and things like that, those numbers add up very quickly to very substantial numbers and cases. But often in the public dialogue, or if the health minister goes to see the finance minister in many countries, my sense is this is not really in the picture because it's not part of their training. Right? So in the US, for example, you have a prevention specialist in Germany, where I'm from, that doesn't exist as a qualification. And those prevention specialists are actually good at making those calculations, right? But most health ministers aren't prevention specialists, right? So I think there's a strong case for making a better case for better health, so there will be more investment so that these people don't have to sit around unemployed, and overall we can tackle this challenge more effectively because there's so much underfunding in many countries.
Okay, so from what I took from that, you've identified two challenges. One's pretty detailed, which is the issue of retention. Yeah. And then a really big meta challenge, which is how do countries actually value health? Yeah. Value health. So, okay, that's a lot to get through, panel. An audience, if we have time, we're going to try and take some questions from you all as well. So start thinking about what you might want to ask if we have time. All right, another question to all of you. So if you could design the ideal global training pathway for the next generation of health workers, what is the core principle that you would put at the center of it? This feels like it's a bit of a toughie. Actually, I'm glad I'm only asking it, not answering it. They're all looking at you again.
No, I can get started. No worries. No, I mean, from our perspective, the two values or two principles, pillars, if you will, of any such trainings and so on would be that's the first one would be the portability, meaning that there is a minimum set of criterias or elements in every curricula that would be common. Because let's face it, I mean, I've studied medicine. Heartbeats, when you learn to hear heartbeats, they sound the same anywhere in the world. So there should be a basic acknowledgement of the fact that the core training contains these basic elements that are enforceable or should be recognized everywhere. So this portability is the first element, and the other one is.
So that would be the central thing for you, portability?
I would say it goes on two legs, the portability, and the other one is the accountability or the responsibility around this. It's that we should also envisage this thing to avoid, all these market failures that I mentioned earlier. So that's really this portability and accountability. So doing this in a fair, transparent fashion that is a win-win for everybody. That's also the second cardinal value that I would put at the forefront in any of these, projects.
So I'll piggyback on that, but I'll say I'll focus on accessibility, which I think comes into some of the pieces of that. So healthcare doesn't matter if no one can access it. So it has to be, we're talking about countries around the world, they look different. Urban areas, rural areas, last mile. We have to make sure that healthcare is accessible. And I think fit for purpose is so important to that. So as we look at accessibility, it's not gonna be the same. I looked at the diversity of the video on Saudi Arabia last night, and they're like, we have mountains, we have deserts. It's not gonna look the same for what you're gonna do in the desert that you're gonna do in the mountain regions. And I think making sure that accessibility is grounded into any healthcare system you create.
Well, I'm not asking about healthcare systems. I'm asking about training.
Training, but with the training, to me, is the core principle of training is to make sure that we are doing a fit for purpose, which I think gets to a little bit of what you were saying on the beginning, which is if we're creating training programs, but we're training people in the mountains, but we really need people in the desert, what's the point? So we have to make sure the training program fits for the health system that we want or the need we want, be it at every level. So I really think that if you have a training program that looks like accessibility, meaning that people can get the training, upscale training in this area to help them. They may need additional training in diabetes work, or these people may need training in digital tools. This training has to think through, what are you training for? Maybe it's a better way to, we have to train for the system that we need rather than just training blanket, generically, which I feel like to some degree we have focused on a generic training for medical support.
Yeah, I'm going to come to you in a second, Stefan. I just want to kind of double click on that. Isn't what you're saying, the idea of accessibility, slightly at odds with the idea of portability?
Goes hand in hand. It goes hand in hand with it.
Okay. Stefan, I know you are the tech entrepreneur on the panel. I might have to ask you in a second to go behind the screen and figure out the screen that keeps failing on us. Roll your sleeves up and do it. But
first, I would pick it out and plug it back in. Let's try the simple things first.
That's the answer usually. Just unplug it and plug it back in. Yeah.
So, so let me just go one level up for a second first, because the training obviously needs to tailor to what's possible in the system. And in the systems, I think one of the challenges we have, nurses are a key part of the system, right? And now on the medical side, everything is very regulated, and nursing is regulated as well, but very specialized is probably the word I should have used on the medical side, right? There's a clear specialization path for each doctor, and that's something that's been adopted globally pretty much, right? A bit rigidly as well, shall I say, back to your point on fit for purpose. How can you make this more competency based so that a doctor who says going into neurology, has certain competency packages that they acquire, their scope of practice can expand as they validate these competency levels rather than like the full multi-year process that we have currently, and especially like countries, African continent and so on. I think there might be some benefits there. There's a big challenge as I see it on nursing and upskilling, and there's a huge degree of global variation. In the US, you have NP programs, so a nurse has a real career path for herself. Once she's graduated, she has a journey ahead where she can go. In Germany, only 6% of the nurses have some degree of specialization, and they're very sort of, kept at a low level in the system, amongst other things, by doctors' lobbies and things like that, The other comment I'll make is I think there's a certain risk also, as we need to be careful from a systems perspective. If we standardize this, to a high degree, there is a risk that the brain drain can accelerate, right? Because if the nurse in Nigeria that has level X and it's an internationally recognized level X, then that can cause problems as well. So we need to be careful with unintended side effects of some of the things we're exploring. Final point I'll make is on your point, if you think about the different settings where nurses operate, like a nurse in rural Ethiopia, might encounter situations where she has to make some pretty difficult ethical decisions on whether, she should should do some kind of, I don't know, improvised type of mini surgery or something on a patient that won't see a hospital in the next 24 hours, but her prediction is that this person will die. Those are different realities than, if we had a car accident just outside here, the ambulance would be there probably 3 minutes or something like that, and the right specialist would be able to look after you pretty soon after, right? And recognizing those realities and thinking about the education process and the different ways we train people for those kinds of less usual situations where they are more likely to occur, I think would benefit the system.
So let's stick with you, Stefan. Let's think about the potential use of technology to actually create pathways that can upskill, that allow for portability, and using AI, the ability to be accessible as well. What kind of digital or blended training models do you think have the most promise?
Yeah, so certainly in terms of upskilling, if you look at the US as a benchmark, so a lot of large NP programs, which is one of our client bases, that we power those programs in part with a lot of digital content by ourselves. Are able to do things without much practical training because the practical knowledge is there, in the fundamental nursing training. And so you can do a lot on the digital front in terms of these specializations and so on, right? But you have a regulator, obviously, in most of these places, and opening those minds and getting them to think in a more localized manner, I think is helpful. And from the, sort of, I don't know what you want to call it, Northern Hemisphere picture or higher income countries, probably a simpler distinction. I think we need to be careful that we just kind of export what we're doing here, and we think that's the answer. I think there's a exciting opportunity in the low middle income countries to actually leapfrog in terms of approaches and methods, and we kind of risk preventing that a little bit if we go in and Germany does this, we build like the same sort of, technician training schools that we have in Germany. Takes years to graduate, takes years to build up the school and so on. And so models where you can work in a hospital sooner, acquire competency bundles, be useful in the system, etc., already earn some money, would be much smarter, right? So let's be careful not to sort of export what we have here, because the technological advances in terms of what's possible, in terms of training approaches, are very different already. And in your typical German university or nursing college, they're not really being deployed yet, but let's deploy them in Ethiopia, Nigeria, and so on and so forth. Huh?
Yeah. So I was just going to jump in. I was in Norway last year, and one of the things that they talked about is the diversity of people in Oslo. They have a real diverse community of people from all over low and middle income countries. And a lot of them are nurses, doctors from their previous countries. And so one of the things that the Norwegians were saying was that you have to have this high level of education to get nurses. So you have to have a college degree, but you have to have a master's degree for this next level, and all these things that make sense in Norway. However, these other physicians who have been practicing for years and nurses were saying, well, we can't even get in the system because we don't match their qualifications. So as Norway's population is aging, they're missing out on all these medical people who they could leverage, but don't fit into the system. And they acknowledge, they're like, yeah, we have to figure this out. And I was like, well, TikTok, when are you gonna figure it out? You have to start thinking through this solution and figure out what works, because you are missing out on these opportunities, you're missing out on these health workers. And like you said, now they'll go somewhere else to another country, a neighboring country, and work there and support their system there. So we all have to be thinking about this a little bit more.
And that's the flip side of the brain drain argument as well, because it's actually a benefit for the countries that are sending workers. And in the work that you do in advocacy as well, it could be particularly advantageous for women as well, other marginalized communities.
Absolutely, and I say this coming from CARE, we are champions for women. That's what we look at. We look at our communities, we look at supporting women in our communities. And so for us, we're always looking at things from a lens of, are we making sure that we're being inclusive, that we're being supportive, because they have different needs and wants. So I think that whenever we think about opportunities for migration, we see it. We see it for opportunities for jobs. It may be simply to go with a partner, their husband, to a place, and they have those skills, and they say, well, now I want to work in this country. So it may not be that was the initial focus, was to find a job, but when they get there, they do. And so we see it for all different levels, but we also see so many opportunities on the other side. And so they get, they can get more money. Income, we know, it doesn't matter who you are. Having your own income, makes life a lot easier. healthier. So we see these opportunities, we see women saying, hey, I was a nurse in my own country, I moved with, my husband to this country while he was studying, and now I can be a nurse in this country. So we see those opportunities there, and then when that first person comes, your community tends to follow. So we see all these opportunities there, and we need to find the right way to take advantage of it, also so that the country they left doesn't feel like they're losing out on an investment made for their local population. So I think it's always two-sided. People migrate for different reasons, and we need to be respectful of that, but at the same time, make sure everyone feels like it's a win-win.
Just can I jump in on that briefly? Just back to your question on how technology can help with that, right? So in Germany, we do this triple win program, for example, which is by the German government. So there's regulations around, the German hospitals will all work with typically ethical recruiters. Obviously, we have the German language part, which doesn't make Germany the easiest destination from that angle. So then there's government funding for those things. But then people are not charged for learning the language as long as they commit to kind of going through with this pathway and so on. So there's ways you can manage that. But if you bring technology in, you can actually turn it into a quadruple win in a way. Because, if you have a system like ours, as an example, you can increase the output of your school with, basically no insignificant extra spend. You can have 25–30% more students, right? Depending on programs. If they don't require practical training, and some don't, on those onward specialization topics, you can scale them dramatically, right? But that often doesn't happen. So ideally, to my mind, we would go into those low middle income countries, help the schools systematically to increase their output, and then take a small share of that. And then we've really helped both systems. And the AI, if you look at tutoring capacity and things like that, our system has an AI tutor built in, for example. And yes, it's, how shall I say, it's different from a human tutor. It has its strengths and weaknesses. It doesn't get tired. It makes less mistakes, probably. But, let's deploy those things to really create multi-win type situations. That would be my point. Let me also use this opportunity to, thank Kate Tolenko, who suggested me to come to this panel in terms of this perspective overall, like this consulting view of the system. Where are there task shifting opportunities? What new roles might that require if we want to task shift meaningfully, and so on and so forth? That's the kind of thing that experts like her can really contribute to when you're dealing with a system. So we don't look at the challenge of education and recognition of credits in isolation, but we look at a specific system. What are their national priorities? How can we create new interim layers of education? How can we execute those effectively? How can we then make sure that the task shifting actually happens, and so on? And then all of a sudden you start to get to an overall intervention picture that's a little more, multifaceted, but has a much better chance at success and is much more tailored to the concrete reality. And then you can evaluate it, like you do, and make sure it actually had the impact in the system that you wanted.
Well, thank you for the pass. Can I jump in? Yes. Thank you for the pass, Chris. As a matter of fact, you're absolutely right that it's not also a matter of education, of the number of people of trained, or the way they spread across the globe. What we know also is to cope with the challenges, the demand in terms of the future health needs of the population and so on. It's a matter of productivity of the people, of the workforce. So it's also this, it's like not either or, it's both at the same time to work on people, on the training, on all these elements, the mobility, but it's also to work on productivity and this element that you bring on, skill mix, task sharing, etc. These are leverages to gain productivity for the health sector. But there is the new, of course, the buzzword of today, AI, that is supposed, like based on our estimates, to improve productivity of health professionals. Still to be demonstrated. I would like to, I'm like St. Thomas, I'd like to see, to believe I need to see sometimes. But, few estimates we get is that we could get some 10% productivity gains through AI. So, these elements are absolutely work hand in hand in this endeavor.
Yeah, and if I can follow up on that. So, and that is something I would encourage, all of you as you think about it. In my daily work, I keep a keen eye on the AI advances, and I try to make sure I understand and test and play with them pretty quickly. Because it's amazing what's becoming possible now, and if you look at the clinical system, both nurses and doctors, the amount of time they have to spend documenting, writing clinical letters, doing all those kinds of things, and things fall between the cracks and mistakes happen and things like that, right? And the AI can help make those processes a lot more efficient. Imagine already today, most of you have used this in meetings with Zoom where you had your AI summary after the Zoom call. Who's had a sort of an AI summary of a meeting already? see almost everybody in this room, right? And that stuff didn't exist a few years ago, right? So now we had like, we would take notes, somebody would be in charge of somebody writing up, and that stuff is smart. It doesn't just give you a conversation of the summary, it gives you a list of the to-dos. What does Stefan have to do? What does Guillaume have to do? And so on and so forth, right? And so if you think about, an AI listening to a clinical conversation between a patient and a doctor, and, he talks about tests, he explains things and things like that, you shouldn't even have to trigger that process. It's recorded while it happens, and then the AI says, here's the suggested next steps, and here's the write-up, and things like that. Final comment I'll make on AI, and then pass to you. Just the limits of what's possible there, I think, are, how shall I say? Initially people say like, okay, AI is not going to replace, creativity and arts and empathy and things like that, right? But one of the early findings from a clinical chat room with AI versus human contributors was the AI made less mistakes and wrote more comprehensive contributions, but it was also more empathic, right? Right? And that's where it gets a bit scary, maybe, because we think, what's special about us humans? We're creative, we're empathic, and everything else, And, I have 2 young daughters. One is 16, like many young girls, the 16-year-old has her kind of, mental health pressures and challenges. And they all want to go for therapy these days. Almost her whole class wants to do that. You wonder to what degree it's a fashion versus a need, but you obviously want to take it seriously. But if you think about AI, being able to read your blood pressure from your face, which is possible already. It looks at the veins. It just needs a video, basically, and can do pretty accurate blood pressure assessment. So obviously, the AI can also read your emotions, your pupil dilations, your blink frequency of the eye, and find signs of stress and whatnot, So from that angle, and it's a pretty perfect conversationalist as well, It won't forget anything you've ever told it, and it'll have some pretty good sound advice in many cases.
There are disadvantages with that as well.
Yeah, sure.
You had me up until that point.
So, but my final point on that is, yes, there are disadvantages, but let's always look at what's the comparison also. Right? If I'm in Germany, like, okay, I can get a therapist for my daughter in Leipzig within a few months waiting time. I was lucky to do that. Some parents are not so lucky. But if you're a pregnant girl in rural Africa with depression after birth or before or whatever, and there's like nothing available to you, then we should think about that.
This is, I'm going to bring you in a second. This is a very interesting conundrum, because while younger patients may prefer AI to talk to be more empathetic, to be their doctor, an aging population, older people don't. Older people want to see the same human doctor over and over again.
So as a mathematician, I would go like, let's follow the data on this, and if it's hard to underestimate the potential there. So there's a company, I don't remember the name, I don't want to do any advertising here, but it's a US-based company that trains an AI to make follow-up calls after operations in hospital, right? And I invite you to find that company and listen to some of the samples that they share. And those are like elderly people after operations and things like that, right? So here's the fascinating thing. Obviously that AI nurse has all the time in the world. She will have scanned the entire health record. She won't have forgotten anything. She'll be way trained to be patient-friendly. She doesn't get tired and what have you, right? And the fascinating number to me was...
It's not going to make you a cup of tea, though.
No. But this is a call, right? This replaces a call from a nurse.
Okay.
Right? So a call from the nurse would also not give you tea, unfortunately.
Okay.
But the fascinating piece...
Finish your point, because I want to move this
to the
along.
point, yeah. So the point is this, the number of people that were happy to have a follow-on call by a physical, real human nurse was 92%. The number for the AI was 88%. 88%.
So pretty close, but still
Pretty,
humans get
very, very close, and the cost effectiveness, availability, scalability, obviously at a whole different dimension, right? So.
Okay, the machines aren't coming for us just yet. All right, Crystal.
I just wanted to bring back a point you were talking about with the use of training and AI and all that. And I wanted to say it works at a community level too. We work a lot with community level nurses, community health workers, and we found the training in their phone, things that we think are just basic at this point, but reminders, things like that, going through tools to be able to walk you through a checklist at the community level. For the phone call, like it works in that certain communities. It's going to work to have that automated call. I'm still I feel like in between generation that I could take an AI or I could take a real person, but I definitely think in some communities it's really nice that community health worker is walking around, knows the community, and has a checklist to go through of things to do, and then that zips off to maybe a clinic 500 miles away for them, that they can check in and say they went through the checklist, the post-op, the postpartum visit, made sure that they had those things there. So it's a tool that also in technology and training that could be done at the community level to connect to the health system more formally.
So this to me goes back to your point about accessibility as well. And also I think leads me to ask you about the role of advocacy and the role of ownership in designing training programs. How do you ensure that the technology isn't leading necessarily, but the technology is doing what humans need it to do rather than leading?
Great question. Because too often we like shiny and new. And let's face it, AI, everything is shiny and new. It seems really super cool, and you're like, this is great. Let's give over all of our access to this so that makes things easier for us. But in reality, the tail can't wag the dog. We need to make sure that you get this done governments need to be involved. They need to co-design these interventions, programs, ideas. One, because they know their communities better than anyone else. And then civil society participates. For me, again, I love the fact that diversity in the room. We need different people in the room so that you can say, oh, we missed this. Oh, we didn't think about that. Oh, we didn't know that, everybody has a phone, or they don't have a phone. They may have physically a phone, but they don't have access to the phone. So we need to make sure that those different experts are in the room so that we design something fit for purpose, because everybody wants us to win-win. We want it to actually work. And I think that that's how you ensure with the advocacy for CARE. We spend a lot of time working with civil society and governments. We don't lead, they lead. And that's why I feel like we have been successful for moving agendas forward, because it's not our agenda. We may have said, oh, well, it worked like this in Tanzania. Well, in Egypt, it's not going to work that same way, and we need to think those things through.
I'm going to take a second just to see if there are any questions from our audience this morning. It's a really vibrant conversation. We have about 10, 12 minutes left. So I just want to take a second to see if anyone has any questions, or maybe you want to be, no one likes to be first, I know that, but don't be shy. Okay, there's a question. Excellent. Thank you for being first. I think we have one microphone. Yes, right behind you. There we go.
Thank you. I can usually project. Thank you for your conversation. I really, really enjoyed. My question is, I want to hear about capacity building in the countries themselves. I hear about brain gain, brain waste, all of that. But wouldn't it help to build the capacity within the countries and then have people decide if they want to migrate? And at that time, you would have the option of the win-win that I'm hearing we're all talking. I haven't heard that yet, because, that's a serious problem right now.
I'll start with the capacity building. And one of the things is for CARE, we're really it goes beyond capacity building, because there's a lot of capacity in country. What we want to make sure we do is fit for service up training. And I think you mentioned it before. This is where you can use AI. This is where you can use regional hubs that come together where it can be in the region. It may not necessarily be in the country, depending on what they need, but in the region, so people don't have to go so far from their families and different things. But I think this is where you can leverage technology, and thinking more urban centers. There's more opportunities, universities that host different, things. You partner with the university, with the private sector to host those things in country. We have to recognize families are different. Sometimes it's like people just cannot get away, but others really say, I really need this training in another place so that I can excel on my resume. And those tend to be younger, right? So I think the option is, I want both available in countries. It shouldn't be that we only say, well, you have to stay in your country and you don't get the global opportunities. It's like we need both. We need things in country, in region, but also opportunities for them to learn about things in other countries or how they're doing it.
So I couldn't agree more, and most of our work, when I was saying about leapfrogging, is to give you an example. We work in Ethiopia. At national level with ministry support and GIZ support initially, also with some support by the Global Fund. And all of the Ethiopian medical schools maybe 2, 3 or so still need to get on the program, but the large ones, all of them, have a dedicated system with very advanced assessment capabilities. For every 2 to 3 minutes of learning, there's formative assessment data for the faculty, so it stays connected to the faculty. They can learn from instructors from Harvard, Yale, Hopkins, and what have you, including local ones. So we add content with local instructors from Tech Baret College in Addis. I don't know if that tells you anything. It's the oldest technical college in Addis. And all of the students have an AI tutor and so on, So, and then we work at nursing and technical and community health worker level as well. And it's just an example, and that's the kind of thing, to my mind, we really need to replicate, because a lot of African countries don't have that kind of support, still have very traditional work with empty Moodle systems and things like that, and the students go and find the stuff on YouTube, but it's not tracked, there's no learning algorithms behind it. And that's what I mean, there's a huge leapfrog opportunity here, and if any of you are, in countries or places where you would like that kind of support, come see me afterwards. We want to do as much of it as possible. It's so scalable, it's so cost effective, And obviously we should also open up opportunities for international rotations and learning, and a nurse to go to a place for 2, 3 years and come back. That's all great. But in terms of rapid impact and affordability, there's so much you can do there, and I'm totally for it. That's our focus, actually. Our focus is not the international migration. We're just starting to prepare nurses now for the recognition exam in Germany, but that's a new thing, whereas all this other stuff we've been doing for years. So.
But there are many opportunities. I mean, what matters here is to understand that we're part of a global social contract, and we're all dependent on each other. And we need to move from a system that is basically not really managed and extremely extractive to a system that is rewarding for everybody. And there are a few initiatives that are on a bilateral basis. I mean, the UK in recent years has set up many bilateral agreements with countries, usually sending countries to build capacity there, and to also find a way where what they gain there is also not entirely lost when people move, because they could come back, because they would be better trained there and better fit for purpose when they come. And the example also that Stefan mentioned that is extremely good in Germany has been, we were discussing this just before, like the global skills agreement that also basically says we are also helping building training capacity in certain countries that is aligned with our standards. Doesn't mean that everybody that will be trained for this will move around, but at least those who will be moving around will have an easier way in, and those who stay, they are better trained. So this is really something, it's a broader ecosystem that requires instilling a bit more multilateralism, so that we avoid these kind of bilateral things a bit everywhere and going in all directions. But that's really something that we can work on.
Super interesting. Okay, let's see. That was a great question. Thank you. Okay, gentleman here, let's get a microphone to you.
Yes. My question is to our friend from Germany. I represent Project Cure, the world's largest humanitarian for donated medical equipment and supplies. And we are very active in Ethiopia. Currently, we are delivering around $16 to $18 million worth of medical equipment and supplies. With my background, I have done a lot of capacity building to different countries worldwide. Every time I delivered a training, all these fancy, beautiful jargons that we used, all policy, this and that, I was faced with the question of, what can you give me tangible that I can touch? All right, so all these capacity, okay, if I don't have a glove, what can I do with that capacity? So my question is whether GIZ and also Global Fund, if your organization is doing anything to do the transfer of technology and supplies and supply chain, basically. And let's see how we can collaborate. I will find you.
Sounds good. No, look forward to coordinating on that. To give you an example, for the technicians and nurses, we produce training on, they have a lot of Chinese equipment. I don't know what you're getting them, but it doesn't really matter. The main thing is that the equipment is there and that it can continue to be used. So we train them on equipment use and maintenance, both the doctors and the nurses, on the Chinese equipment that they have with educators that are local. We just help them make that process more efficient. So, for me, it's all about partnerships. So one should link up. There's a lot of fragmentation still as I see it, So maybe also building on the last question, one thing that would be beautiful to do across Africa would be a pan-African effort on, primary care, maternity, health, child survival. And there's still a lot of fragmentation. And you could work with Africa, CDC, and others to do really, maybe the Saudis can can fund it, so here's a suggestion, because I think, with fairly affordable means, you can do a lot there. And that's on the education side of things, and I think there's a high return on investment there. And that doesn't mean, of course, that you shouldn't get ultrasound machines in and so on and do that as much as possible and as fast as possible as well. But it should all go hand in hand and reinforce each other, in my view.
I just want to bring up the point of incentives and politics as well. I don't know if you want the environment we live in. How do you build those incentives? What are those incentives? How do you make that system work? Everyone's looking at everybody else now. No one wants to jump in first.
I'll just jump in and say nothing is perfect, right? We'll start with nothing is perfect. We all have heard of programs where you get education paid for and then you commit 2 years, 4 years in less desirable places. It may be the rural part of your country. It may be the hottest part of your country. It may be whatever, wherever the needs are. And I think that those have existed for years. I think as years have gone by, versions of those programs have gotten better and better. I think as we look through and start thinking through, I'm drawn to the Human Resources for Health session at the WHO a few years ago, where you had a minister coming from an island nation basically say, it is no way, if I send someone to the UK, they're not coming back. And because they're going to get a big country, big city, they're not going to come back here. So our incentive is for us, while we're building a medical school in the region, is for us to make them sign contracts to say they'll come back and work at least 2 to 4 years here. And they found that that worked because people were, one, they wanted the schooling, but two, they knew that they had to come home and complete. Now they said some of them, they said they were at about a 50-50 rate of people staying after that, but it was an incentive to get them to come back. And I think we have to think through those things. As far as the receiving country, most of them really need it. So they're like, yes, we'll get, health workers, all but a few countries now, we know. But they say, we'll take it because everyone needs health workers. But I think we have to find a way to equitably do this so that everyone does feel like this is a beneficiary.
No, I totally agree. I would like to follow up on this. This is the question of retention of staff. I mean, how do we keep them? How do we keep them in the profession? What perspective do you give them that makes them feel, this is really worth continuing this way? So this question of incentives is essential. And I know time is running out. It's stressing me like this, blinking on my face. But the thing is that what we need is like clear career prospects. Even in high-income countries, in OECD countries, it's difficult sometimes in some countries for professionals to say, okay, there is a future for me. There is something that makes me progress in the profession, like a country like Ireland, training hundreds and thousands of doctors every year as a huge out migration rate, because there is basically a very difficult career pathway there. First. Second, working condition. It's absolutely essential. People need to stay in the profession. They need to be happy with it and not burn out and so on. So this working condition is not only in the profession, but as part of the system as well. You have a health system that's functioning, that you don't have to fight against windmills all the time, etc., etc. So it's very important, working condition. And the third one is the question of recognition of your worth, of responsibility, of your value within the system, not mentioning, of course, your training and degrees, because this was one of the things heavily discussed these days. But the recognition of your worth by the authorities, by the countries, are also among the important triggers. So yes, I like this idea of that colleague from a small island saying, if I send them, they will not come back, but work on what you're doing at your national level to have them come back and feel like they belong where they are.
Yeah, I mean, that actually harks back to a conversation I had on Monday with some panelists about really investing in healthcare workers in your country. So there's a career path and a reason for them to come back. Stefan, very quick point from you. Then
Personally, I'm a big believer in incentives, whether it's behavior change at the individual level, climate change, healthy behaviors by patients, mobility, etc. You make the education free. Somebody commits to do something for a few years. Ultimately they need to be a free human being to decide where they want to go. But if they get something for free initially, that opens up new path for them and so on. That's only fair enough as far as I'm concerned. The other final point I'll make is was just thinking as I was listening. Part of what we discussed is there's a lot of change needed in these systems. systems, right? And the way we train the healthcare professionals who understand them best, because in the end, obviously, there's a certain complexity to many of these, processes, diagnostics, treatments, everything else. So we need to train the healthcare professionals, to my mind, a little more broadly, right? In our curriculum, for example, we have a whole business section around change management, AI in healthcare, that kind of stuff, because they should be the change agents. Because they know the system from the inside, they know where the problems are. So if they learn about, process analyses, change management, these kinds of things, that can really help make them agents for, evolving the systems in terms of efficiency, et cetera. So that would be my final plug, to set an incentive for that, because it's all very focused on, they need to know their job, but they're not really trained to think beyond the job and the system and how to change that. But we need those leaders at local level, at hospital level, at government level, et cetera. And so let's incentivize the educational institutions, or even mandate, to make these things part of the curriculum.
Okay, panel, we're out of time. Guillaume is sweating looking at that clock. Poor guy. Poor guy. Don't worry about it.
Very, very stressed.
We're good. We're good. Terrific conversation. I'm sure you could talk more about this. We are out of time, as I said. Thank you for the questions from the audience as well. And I'm going to invite you, please, to give our panelists a round of applause as you leave the stage.